Welcome to the Health Deli, your local stop for a fresh take on community health topics. Come on in, grab a number, and let the guys behind the counter, Mark, Ben, and Mike, tell you about today's specials.
Hello, everybody. Welcome back to the Slim Deli. Back sooner than expected.
Thank you, Ben. Thanks for noticing.
Yeah, you're looking real slim today, Mark.
Thank you.
Yeah,
Thanks a lot.
in the tie. I don't know if we can catch that on camera, but
Yeah. Would the real Slim Mark stand up?
and yet he stays sitting.
Right, that's the
Slim Shady.
it's an M&M reference. I've had too many M&Ms as well.
Yeah, for sure. All right. Anyway, so that was a great start to this episode of the Deli.
To be honest with you, I'm just sitting here going, I don't even know what to say
That's
with
fair.
these two right now.
That's fair. So as we all can see, I got the fabulous Mark on the line with us, and Mike,
The fabulous Mark
and Mike.
and Mike.
Yep. And we got Andrew and Rylan in the studio as well.
Hello.
Yep.
Hi.
Yep. One of these days, Andrew will remember to bring enough microphones for everybody.
You know, it's hard to ask. It really is.
He could use yours.
I don't contribute anything.
That's fair. That's fair. So today at the Slim Deli, no one called me out on changing the name.
Well, no, wait.
so-
Yeah, don't
what
forget,
why do you always change it?
we're in the Health Deli studios here. Don't forget to credit the studios and the wonderful people here at the Ferris State University.
Right. It's not the Slim Deli Studios. It's the Health Deli Studios.
That's fair. But we, have guest pods every now and then. But
That's true.
But thank you, Mike, for bringing that up. Because yes, fantastic space we have here. So thank you to all the people at Ferris and the digital health team, or digital media team, I should say. So yeah, today we're talking kind of about the same thing we talked about last episode, which is
Deja vu all over again.
It is, which is why the Slim Deli's back. So we're talking about GLP-1s and weight loss. And that's because even though we recorded this episode literally 1 week ago, there's already some new information that we need to put the last episode in context. So,
Or Ben just did a horrible job doing research for the initial program, and he can't follow instructions to turn his phone on mute.
so I do have my phone on mute. So I don't know why that happened. But anyway, so yes, that's what we're going to be talking about today. Before we get into that though, Mike, are you working on any episodes, any free samples?
I do. Working on a couple things, actually. Working on one about seasonal affective disorder. That one's coming up very soon. Working on one, just starting to think about putting together an episode on longevity. Maybe some case reports about people who've lived a really long time.
Like me.
Yeah, talking about gender differences in longevity and just kind of about that, how to live to be 100 or 150 or whatever.
Okay. Yeah, that could be interesting.
Oh, is it my turn?
It's your turn, Mike.
Okay, well, nobody said, Mike, it's your turn. How about you? They just all sit and look at me.
Yep.
So I've been working on a couple of things. One, looking at antibiotic use in the community and some of the things that have impact that. Also, remember back previous seasons, we've gone out and asked questions of kids and college-age kids. I'd like to take that to my generation and go ask the grandparents.
That'd be great.
Yeah, what health questions that they have. Now, we'll have to talk loud so my peers and I can hear.
They might have Meniere's disease.
What?
We don't know. Exactly. Exactly. And I really hope that you ask them all if they've heard of the Health Deli before, because I need more of those sound clips.
Oh, yeah, that is definitely our demographic.
Fantastic. Cool. Well, awesome. Glad to hear that you all are working on that. And so, yeah, let's go ahead and kind of talk about those GLP-1s and weight loss.
Now, help me. What the heck does GLP stand for again? I can never get that right.
Yeah. So it's a glucagon-like peptide, I believe, or is that what it is? Right.
Yeah.
Okay. And so these medications, they are, let's just talk about what their actual names are. So the generic names are semaglutide, liraglutide, and tirzepatide.
They sound like dinosaurs, or maybe like the Ninja Turtles. Rag.
I don't even
if
know.
Andrew had a microphone, he could make funny comments, but
But we'll have to get to him for next time. But those are the generic names. The brand names that people have probably heard of are Wegovy, Saxenda, and the newest one that's been approved is called Zepbound.
see, I don't even know what's worse, the generic names or the brand names for these. They both sound loco.
I mean, a little bit, but I like Wegovy. That kind of like rolls off the tongue. It's kind of fun to say. I don't know. We are not sponsored by Wegovy, by the way.
We should do an episode about brand names, because there's actually a lot of thought and regulation that goes into establishing a brand name for a medication.
Yeah, that's a cool idea because I do also at some point want to do an episode about brand versus generics. Is one better than the other?
Yeah.
That kind of thing. So yeah, we can
Kind
talk
of like
about that
with
too.
Mark and myself. I'm brand. He's generic.
Right.
Yeah.
Or generic.
You're a degenerate.
We got
generic.
we got Mark at
Bobby
home over here.
generic.
Yeah. So how did that last episode end? So as I mentioned, we
Poorly.
just talked about it. True, but we just talked about this 2 weeks ago. That's the last episode, and the conclusion we came to essentially was these GLP-1 medications. They do appear to cause a decent amount of weight loss. It was 10 to 15% of total body weight. So that's noticeable, right?
I'm looking for 30% on anything, but 10 to 20 is substantial.
It is pretty good. 30% weight loss. That actually would be solid too, depending on how heavy you are. So yeah, we knew that it did cause weight loss, but there was two main concerns that I had before we could start recommending these to everybody. First off, do we actually see a difference in some of those health outcomes that people really care about? Do these medications decrease your risk of heart attack? Do they decrease your risk of stroke? Do they decrease your risk of dying? We didn't really know that at this point in time. Now there's a study that come out, so maybe we do know about it. And the other thing I brought up is these medications are very expensive. I think last episode I quoted that it's about $2,000 a month to be on one of these medications. It has since come out that it's probably more like $1,300 a month. So
Still a lot.
cheaper, but yeah, a decent amount of money. And so is this worth that much money? Can people actually afford to be on these medications? That's really what...
Well, if they're on the medication, they can't afford food.
Well, I mean, I guess so.
Is that
That's one
maybe how
way
they
to
work?
Yeah, maybe that's the way.
one way
Okay.
to lose weight. So yeah, those are kind of the questions that I still had left hanging at the end of the last episode. And like I said, since then, literally 1 week, we have new information about both of those things.
It's like people were listening to our podcast and decided to publish stuff.
I think so. I think it's Novo Nordisk specifically was listening to the Health Deli to an episode that hasn't been released yet. And they decided, we
Which
gotta
now
be on it.
now creeps me out. I think our Health Deli studios are bugged.
Andrew? Oh, he said no. He said no. So therefore it's fine.
But he didn't actually say it. He
Yeah,
just shook his
yeah.
head.
He cannot affirm or deny.
Okay.
Andrew Ryland, blink twice if you're being held hostage at this. So yeah, those are kind of the questions that I'm hoping to really go into with this particular episode. Sound good?
Well, that's kind of cool, though, that we left with those questions and then showing how quickly data comes out and being able to like address those questions. So, I mean, I think this is really cool.
Yeah, it's sweet the way that, just like you said, stuff is coming out every week and we don't really get the chance to talk about it that quickly. But in this case, we do.
Right. Well, you hear the Health Deli and people do stuff. So,
Fact.
what is the meaning of life?
That should be
2
another
weeks, we'll
episode
know.
of the Health Deli. For sure. Okay. So I looked at the newest study that came out that looked at Wegovy specifically, but we can just use that as kind of a blanket for most of our GLP-1s, so semaglutide, and it looked at how this medication decreases risk of heart attack and death, essentially.
And so with that, we talked about that, weight itself, not a big thing. It's everything that comes with it. And one of the primary things, with obesity that we see is increased rates of death, from those factors. So, okay.
Right.
So if you're decreasing your weight is cosmetic, but the other outcomes,
Right.
Okay. So
Those
these
are
are death is big.
Right. And that's things that insurance companies care about too, right? They want to prevent their patients from dying. Heart attacks are very expensive as well. So they want to try and prevent heart attacks. And so this is how you can kind of get at making it so insurance companies will pay for some of these medications.
All right.
All right. So as I like to do with all these studies, I'm going to describe just kind of the methods and the results to you both, and you guys can let me know what you think about. Sound good?
Sounds good to me.
All right. So let's start with our patient demographics. So who are the patients that are actually in this study? First off, all these patients had or could not have diabetes. So you had to not be a patient with diabetes in order to be on this. With that said, about half, a little bit more than half, had pre-diabetes. So they weren't fully diabetic yet, but were close to being diabetic.
But that's kind of indicative of our population in general.
Yeah, especially in the United States.
And especially those seeking weight loss.
Yeah, for sure. So this is a good representative population, at least based off of that. The average BMI was 33. So if you remember from the last episode, if your BMI is over 30, you are obese. If it's over 25, you are overweight. And so we kind of want you below 25 if we can.
We did calculate my BMI, Mark. You missed it. I think I'm at a 24. So
24.
100.
Squared.
Something like that. But yeah, so we had obese patients. So these are the patients we would want to consider using this in. And then last thing here, there was about 8,800 patients in both arms. So
In both arms.
both arms. So about
Okay.
17,000 patients were included in this study. Does that sound like a good amount to you both?
It does. So did they exclude, or what was, I guess, their target BMI? Did they mention that? Like, because obviously they wouldn't want a bunch of people who had a BMI of 20.
Yeah, so I actually don't know. I didn't write that down. They did want to specifically look at people who were overweight, though.
Okay, sure.
Yeah.
Of course. Makes sense.
Yeah. Okay, so that's our patient population. Pretty huge patient population, indicative of what our patients look like
Was
in
that
the
kind
United
of a
States.
pun?
Terrible.
No, but I'm glad you brought it up. Okay. So what was our intervention? So what did we actually do for these patients? So one half of the patients, so about 9,000, so 8,800, received a GLP-1 for 3 years. So they followed these patients, gave them a GLP-1 for 3 years. And then the other half, they just gave a placebo to. So, a sugar injection, not actually sugar injection, but a water injection. So something that's not actually going to do anything. So 9,000 patients got the GLP-1, 9,000 got placebo, and this is for 3 years total that they got medication.
So again, this was one of our major criticisms the last time that the study length and duration was too short, that you could lose the weight, then gain it back, and there might not be a good long-term effect. So 3 years is a long study.
Yeah, but another thing to keep in mind is that these patients received medication for that entire 3 years. So this isn't something where we treat for a month and then you're off it for after that. You're going to be on the medication this entire time.
And is this a once weekly injectable?
Yes, once weekly injectable. You got it. Okay. So what did we find? What were the actual results? So first off, they still found a weight loss difference. So weight loss for the GLP-1 group was about 9% of their total body weight.
And that was sustained over
Yep.
3 year. Wow.
So that was
Okay.
at the 3 year period.
That's significant.
Yeah, for sure. And for placebo, it was around 1%. So a difference there of, about 8-ish% body weight reduction if we compare those two.
If you did a cost versus benefit analysis, I feel like the placebo is a much better deal.
Because it's 1%.
Because it only costs $1 probably, and you got 1%.
I mean, I guess that's true, but it's also over the course of 3 years. So if someone weighs, let's say, 300 pounds, that's 3 pounds.
So Mark now is thinking like an actuary. If you die quickly with inexpensive stuff, that works.
Wow, that's a deal. No, definitely not. So that was a statistically significant difference. So we thought, yes, the GLP-1 is definitely causing this weight loss. Makes sense. All right, now on to the more interesting outcomes. So first off is a composite outcome. So if you may remember from our previous episodes, a composite outcome just means if a patient has any of these things, we count them as one event. So either a heart attack that's not fatal, so you didn't die from it, a stroke that's not fatal, or all-cause mortality. So if you had any of those three things, so if you died, if you had a heart attack that did not kill you, if you had a stroke that did not kill you, then you were considered in having this outcome. Make sense?
Okay.
Okay. So for the GLP-1, it was 6.5% of patients had this. And in the placebo group, it was 8% of patients that had this. So about 1.5% difference if you received a GLP-1. So you were less likely to have one of these outcomes.
Okay. So the percent doesn't seem that big.
Yeah, the absolute risk reduction.
Right. But when you're looking at the number of patients that are in the study, thousands, even at 1%, that's
It's a decent number of patients, right?
yeah. And I'd like to be one of those patients that don't die.
Right, for sure. And so actually, we're going to look specifically at mortality in a second here. But this was a statistically significant result. P-value was less than 0.001. So it appears that this difference was not due to random chance. The GLP-1 specifically was preventing these things, it would appear. All right.
Okay.
And so next is just all-cause mortality, so death for any reason. With the GLP-1 group, it was 4.3%, and in the placebo group, it was 5.2%. So that's about a 0.9% absolute risk reduction with our GLP-1. Any thoughts on that?
The percentage is getting smaller.
It is. It's definitely getting smaller.
Yeah, which would obviously leave you to believe that the MI and stroke effects are greater than all-cause mortality.
Yeah.
So
Yeah, for sure. This still was a statistically significant result, though, so we don't think it was due to random chance. We do think that the GLP-1 is actually causing this difference. Okay. But I like that you're both bringing up the fact that these are really small percentages, right? Like 1.5%, 0.9%. Like that's not huge. And so that's going to come back in a second. All right. The other thing I wanted to bring up was side effects. So we talked about side effects with GLP-1s in the last episode. The main thing is people get nauseous. They get kind of these like stomach upset kinds of side effects. And so they did actually see more patients in the GLP-1 group discontinue the medication due to side effects. So for the GLP-1, about 16% of patients discontinued it due to a side effect. For the placebo, about 2% of people discontinued it due to a side effect. Again, statistically significant result.
So when they did the analysis, then looking at the effect of the medication on all these things, how long was the average person on the medication? And did they account for those people that dropped out at some point in time?
Yeah, good question. And so they did report that the average length of time that people were on the GLP-1s was, I want to say it was like 34 months, something around there. So right around 3 years, as I mentioned previously. I don't know if they took patients out if they stopped taking the medication. I'm not sure. Sometimes studies do that, sometimes they don't, but good question.
Okay. All right. Well, I mean, still, death is a pretty solid endpoint. And if even it's a 1% difference with 8,800 people, that's 88 people. I guess we always have to look at then, unfortunately, like cold-hearted Mark said, does the cost justify the outcome?
Right.
And stuff like that. And the other thing is they only looked at mortality. There's a term morbidity, which is kind of like, even though you don't die, are you suffering from other things? So if you had a stroke and it didn't kill you, are you left, incapacitated and other things? So, I would have liked to see event rate and not just mortality associated with this then as well.
Yep. And so the full study does break it down by, heart attack specifically, stroke specifically. So there is more information in the study. Just for the sake of time, I didn't include all of that.
Okay.
But you're right. Those things would be great because death isn't the only thing that matters, right? If you have a heart attack, you're going to have a bad time.
Yeah, for sure. And it really matters if you're the one person in 100 that doesn't have the heart attack,
Right. Yeah. The individual is definitely something too. It's not just percentages and population levels.
Because I always say statistics mean absolutely nothing to the individual.
That's true. That is true. All right. And so let's go ahead and pause it here for the healthy minute. And then we're going to go ahead and talk about some of the cost things that we've talked about. So why don't you go ahead and take it away, Mark?
All right. Let's pause for the healthy minute brought to you by the winery at Young Farms. Today's healthy minute is read over-the-counter medication labels carefully. Every medication that is available without a prescription in the United States is required to have a drug facts label. These labels follow a standard format much like the nutrition facts labels on foods. These labels give important dosing information as well as information related to potential side effects. The labels also inform the user as to which people can safely use the medication, such as kids, older patients like Mike, or pregnant women. If you have questions regarding the information on the label, please talk to your pharmacist. That was the Healthy Minute, brought to you by the Winery at Young Farms in Mecosta, Michigan. Please visit www.thewineryatyoungfarms.com for more information. Now, back to the Health Deli.
Boom, chicka, boom, healthy. I like how I've even seeped into the Healthy Minute.
You seep into most things, Mike. It's problematic. Well, thank you for that, Mark. Now let's go ahead and talk about cost, because that's really the elephant in the room here. Because it appears that these medications
I thought that was Mike.
Beat you to it.
I had it queued up and I couldn't get there.
That was impressive. Because that's not even in the script. So you guys just came that up on the fly. So let's talk about cost. Now, when we first talked about cost, and again, we're going to pick on Wegovy, but this is true of pretty much all GLP-1s. So Wegovy at this point in time, we believe costs around $1,300 per month. And that's for the 4 pens, and you take 1 pen once a week, essentially. Now that we have information about rates of mortality, rates of heart attack, that kind of stuff, we can calculate something that all pharmacy students dread, which is number needed to treat these things. Do you guys remember how to calculate that?
I don't even know what that is.
Isn't it just a minute now, it's the inverse of the absolute risk reduction. Is that right?
I actually don't know the calculation off the top of my head either. So
okay, I could be wrong. Do not quote me.
We will not quote you, Mark. So essentially what the number needed to treat is, Mike, since you brought that up, how many patients do I actually need to give Wegovy in this situation to prevent one bad outcome? So how many patients do I need to give Wegovy to prevent one heart attack, stroke, or all-cause mortality, essentially? And so based off of this study, using statistics specifically from the study, I need to treat 67 patients with Wegovy to prevent one heart attack, stroke, or death from any cause, essentially. All right, so now we can do some fun math, which I absolutely love calculating when we're doing these kinds of studies. And so remember, we had to treat patients for 3 years to see this effect, right? That's what we did in the study. So if we have $1,300 per month, 12 months in a year, for 3 years, and then 67 patients. So if we multiply all of those things together, it'll tell us how much it actually costs to prevent one of those things. Follow me so far?
Mm-hmm.
All right. So that is $3 million, if we calculate that out, to prevent one heart attack, stroke, or death. Any thoughts on that?
If it was my heart attack, stroke, or death, well worth it.
I wouldn't even pay $1 for yours.
Yeah. And so that's a lot of money, right?
It's a lot of money. It is a lot of money.
Yeah. And this is where pharmacoeconomics is kind of funky, because is that
like the Cold
worth
Medina?
it? Like, yes.
Similar.
But we're getting into conversations that are not very fun to have, right? So how much is it worth to prevent a heart attack, a stroke, or a death? Is it worth $3 million? I don't know if either of you want to weigh in on whether you think it is or not.
I really don't want to weigh in on that. I mean, there's so many things that are part of that. Can you put a price on human life is the ultimate question.
Yes, I can.
I can put one on yours. But
that's why healthcare's messed up.
You're right
now, because everybody's willing to spend $3 million to give grandma or grandpa one more day. And that's a problem with us, because at some point in time, I'm a public health person, kind of like perspective. I could take that $3 million and do so much more good through preventative medicine than what that one person would give. Yeah. So I would say, from a public health standpoint, that's bad use of money. Where I could go vaccinate millions of children for something like that, or like they're doing in proposing to do in like California. It's like, instead of taking that money to pay for that, let's get houses for the homeless. I mean, because at $1,300 a month, that's rent. That's a pretty nice apartment in some places.
Yep. Yeah, if I was an insurance company and I was looking at covering the cost of this medication, just in very uncertain kind of way to talk about it, like not a very empathetic way to talk about it, would be, if we pay for this medication, is saving that person's life going to ultimately increase our premium collection, basically? So you're trying to save that person so that they can pay their health insurance premium. And if it costs $3 million to save that person, to keep them paying their premium, there's simply no way there's going to be a return on that investment.
Yeah. And so we're going to come back to that idea about insurance covering and what that actually means. But I do also want to touch on something you said, Mike, where we could use that money potentially more effectively or efficiently somewhere else. So let's talk about another medication called atorvastatin. So I know you both are well aware of atorvastatin. The brand name of that one's Lipitor, but it's available generic now. It is another medication that helps prevent heart attacks, prevent strokes, and potentially prevent death from those things. Okay, so atorvastatin, if we look at just the average wholesale price, which isn't always accurate, it costs about $150 per month for atorvastatin, okay? If we do the same exact math to try and figure out how much it costs to prevent one death using a different study that we're not going to talk about, but doing the same idea with the same math, atorvastatin costs $441,000 to prevent one heart attack. So that's about 7 times cheaper to prevent a heart attack using atorvastatin than it is using Wegovy.
Yeah, and now that atorvastatin's generic, it's even less expensive than that.
Is it even less expensive than the 150? Okay.
Oh, yeah.
I was basing that off of the generic, but I believe you.
30% cheaper?
Maybe
significantly.
So that's kind of just getting at that, right? Where everything is an opportunity cost. If we spend $3 million preventing one heart attack with Wegovy, Well, that's $3 million you can't spend on something else. There's a finite amount of money that we can spend on healthcare stuff. And so, yeah, making those decisions is really hard. And that's the stuff that insurance companies are doing, essentially. And so last bullet point here, I just wanted to also calculate how much it costs to prevent one death with Wegovy. So the number needed to treat here based off of that past study was 101 patients. So up from 67 that we previously looked at. So to prevent one death with Wegovy using the same math, it is $5 million to prevent one death.
Yeah. So it's even worse than I thought. I thought the 3 million was mortality. So,
Right.
Wow.
Yeah. And so mortality specifically is almost impossible to determine like the actual value of. For stuff like heart attacks, you can look at like, okay, how much does a heart attack hospitalization cost? So if we're like preventing a hospitalization, is that going to make up our cost? Spoilers, no. A hospitalization from a heart attack is like, several tens of thousands of dollars, but it's not anywhere close to $3 million.
Right?
Yeah. So yeah, very, very difficult going on here.
So it sounds like, yes, these medications have an impact. Yes, they prevent the event. Yes, they prevent death, but at quite a big economic cost.
Yeah. And that's why we need people doing pharmacoeconomic kinds of studies. And like, we should have gotten Dylan back on here to tell us about the economics of this kind of stuff.
Or like I said, maybe we'll have to get my brother on. He's actually a health economist.
Yeah.
And does this kind of nonsense.
That would be a great episode.
You don't know my brother.
Is he anything
I
like
think I
you?
know your brother.
Yeah, you might know my
I
brother.
think I do know your brother.
Yeah.
I haven't met him. I haven't had the pleasure.
Would you call meeting me a pleasure?
No.
Okay. Then pretend like there's two of us in the room then.
Oh, we might.
I feel like you might cancel each other out, though. That's kind of the idea I'm thinking, right?
Maybe they'll like go after each other,
And then we're safe.
and then
we can be positive.
Yeah, and then we can like bloom.
Love that. Love that. Okay. So, Mike, you sent me the other article that made me want to make this follow-up episode. And that was the article where Novo Nordisk essentially came out and said most insurance companies should be covering Wegovy. So again, Novo Nordisk is the manufacturer that makes Wegovy. And they said for most patients with insurance, Wegovy was only going to have a $25 copay compared, to pick it up for a patient. So my question to both of you is, doesn't that solve our cost problem then? If the copay is only $25?
Solves it for me. I'll pay $25 for a whatever percent reduction, risk reduction for a heart attack. That sounds a good payoff on my part. Yeah.
Honestly, and I have to think if just under my own perspective, not for the greater good. You're right. Yeah, I mean, $25. Yeah, I'm in.
And if that's what I think the medication costs, heck yeah. I mean,
exactly.
that's good money for me.
Yeah, for sure. But you just brought up a very important thing. I think you did this on purpose, Mike. If that's what I think the medication is worth, then yeah, totally. But let's remember, the cost of Wegovy doesn't just vanish because the copay is $25, right? So yes, for a patient to pick it up, it costs $25, but the manufacturer is still charging $1,275 additional dollars that have to come from somewhere. It's not going to just vanish.
So my insurance company is going to end up paying for that. And they're not going to just pay for that out of the goodness of their collective corporate hearts. I imagine that they're going to increase my premiums much more than $25,
Right. And the premium being the amount you pay monthly just to have insurance. So yeah, they're probably going to increase those premiums because A, if they don't, they aren't going to be profitable. B, if they don't, they're going to go out of business, right? Because they're businesses.
Right. But they're only going to increase premiums for people that are using Wegovy.
That's not true, Mark. And you know that.
Because that's how insurance companies work. They pool together healthy and sick people to spread the cost of the care. However, you will take your pre-insurance physical, and if you have certain health attributes, you might get dinged even more, especially because then they think you might go on this medication eventually. So it sounds like now that I'm talking this through, I'm going to end up paying for this anyway.
Right. You're going to end up paying for it, and other people that aren't on it are also going to end up paying for it, right?
Well, bleep that.
Yeah. And I mean, that's private insurance. If we talk about public insurance, so things like Medicare or Medicaid, if those formularies also pick these up, that's going to be increases in taxes for people, right? For the most part. Either that or cutting other social programs that the government is doing.
Darn you, Wegovy.
Darn you, Wegovy, indeed.
Yeah, I mean, you could do some rough math if you knew the incidence of obesity in the United States, which is probably
So we did that in the
Very
last
large.
episode.
Oh,
I want to
okay.
say it was like 60-ish%. It's very high in the United States. And so
that
there
could
are
be.
dollar signs in Novo Nordisk's eyes when they can see, oh, we can have all this covered for all these people with obesity in the United States.
Oh, you mean drug companies try to make a profit?
They try to make a very large profit,
Gotcha.
it would appear. All right. And so that's kind of the copay idea. And that made me think that's a very common problem in the United States. We use a lot of very expensive medications here. We use things like Entresto, which is very expensive. We use things like Paxlovid and Remdesivir, which are very expensive, which may or may not be used as often in other countries. So my question for both of you, which I think you both know the answer to, if the United States pays so much more in medication costs, our outcomes must be a lot better, right?
No. Unfortunately, no.
Yeah. And so I have just some numbers here to round out the episode to give everyone an idea of what we're talking about here. So the cost of healthcare in the United States per population, so per capita, in 2022 was $12,500.
So that's how much we spend each year for one individual.
Essentially.
Okay.
Essentially. And so that's kind of nebulous though, right? Is that a little? Is that a lot? I personally don't know.
$1,000 a month for every man, woman, and child in the United States is a lot.
Sounds like a lot, but what about other countries, right? Does everyone else also spend that much?
No idea.
So that's where these other numbers come in. So the second most that is spent on health insurance or healthcare. So first is the United States at about $12,000 a year. Second most is Germany at about $7,000 a year.
Whoa.
So
Half. A
about
little more
half,
than half, yeah.
right?
Wow.
And then number 3 is Switzerland, again at about 7,000, and the average amount is about $6,000 per year.
Okay, but that's the cost. But what about the life expectancies? Are we living longer because we're spending more?
Right, great question. We would hope so, right? We're spending about twice as much as
So
the
we should live
average
twice.
country.
We should live twice as long.
You would hope so, right?
You would think.
Yeah.
I think we do.
What do you guys think? You think we live twice as long as other countries?
I don't think so.
We're asking Rylan and Andrew, and they're shaking their head no. And unfortunately, you are correct. So I had just looked up some outcomes compared to other countries, and I'm just going to tell you how the U.S. does in comparison to most other countries. Are we average? Are we below average? Are we above average? That kind of thing. All right. So our outcomes are average to other countries, so about the same as other countries when it comes to death from heart attacks and control of things like asthma, so breathing.
But when you say average isn't good.
Right, especially for spending
That's
that
kind of
much
just
money.
the middle
right?
of the road. We'd want to be better than average. So we're not better than average?
Not in those things. And I actually did not see anything that we were significantly better than average on for the website I was looking at that compared these things.
Obesity.
We are higher than average in obesity, which is a bad thing.
Oh, okay.
And so there are also some things that we were worse than average on as well. And so just the ones that I brought up here are infant mortality. So unfortunately, a lot of children die in childbirth in the United States, more than in other countries. Also control of diabetes. And so our control of diabetes is worse here than it is in other countries, which is interesting because we're spending a lot of money on things like Wegovy, which can potentially help diabetes. And then lastly, we are worse than average when it comes to life expectancy. So even though we pay twice as much, we actually have less life expectancy.
Less than average.
Correct.
Well, and this brings up something that I want to talk about in a future episode is social determinants of health. And we kind of alluded to that before when we talked about pollution because there's so much more that will impact your life than just the medications. If you have to treat something, that means you're already on a path to bad. And if we can look at what influences the diseases from occurring in the first place, like pollution, like access to healthcare, access to good food, and stuff like that. And that's the problem. We're a supersize it, all you can eat kind of buffet country. And then, hey, they'll fix it because we got Wegovy, on the back end. And so we just assume that I take zero responsibility and someone's going to pick up my tab.
Yeah, there is part of that to the United States. There's also some people just don't have choices, right? Like if you live in the inner city and there's no clinics around you and the only food is fast food restaurants, you don't really have a choice, but that's kind of what you're going to do.
Well, we
right?
always talk about like health deserts. So meaning that you live in an area that has no healthcare providers in close proximity. There's also, healthy food deserts or fresh food deserts. And like you said, the closest place you can go is, that gas station with the hot dog on the roller that's been there for 16 years.
Right.
That's not healthy. In defense, though, of the United States, and I wish your brother was here to talk about this because I probably am posing more questions than answers. U.S. patent protection of medication, like exclusivity, may not extend, or doesn't in a lot of cases, extend to other countries. So I do think other countries can benefit from innovation started in the United States.
Well, and that's the case. And, part of it being that we make the justification that sometimes we have to help out those countries that have less means. But now the problem is, and this is coming out more and more, about unethical patent life extensions. Because if I take an old drug that costs a lot of money and now I tweak the delivery device, put a new spring in there that costs 75 cents, and now I get a 10 years extension on my patent and can charge thousands of dollars instead of $10.
Yeah. So my point is, there are countries that are going to be producing medications that are essentially Wegovy, but the innovator here in the United States is not going to be receiving any profits from that, but yet they'll be benefiting from that medication potentially.
Yeah.
I'm not saying they're not doing that, in Europe necessarily, but there are places that could do that.
And again, the idea of patents would be interesting because theoretically patents, are recognized and observed and honored across the country. Now, that does not mean that some countries, go against that and, don't do that or do counterfeits or knockoffs. And so, there's a whole bunch of other stuff. But, to develop the compound to begin with, the drug company bears the brunt of that.
Yeah.
Yeah. I'm starting to sound more and more that we really need to get your brother on here to talk about
It'd be so
pharmacoeconomics.
Yeah.
Because it's super complicated as we're barely scratching the surface.
We don't have to tell them it's interesting. We don't have to tell them that, we really value his opinion. All these things would be bad to tell him.
But I do. I don't know him. He sounds like a great person. I'm sure we'd be fast friends.
Oh my goodness.
So unfortunately, that's kind of a downer ending, but that does bring us to the end of this episode of The Thin Deli or The Slim Deli.
I like the Slim Deli.
The Slim Deli? I forget what I called it. Slim Dog Millionaire, if you will. And so, so unfortunately, we don't have a clear answer on, should everybody be on GLP-1s? They appear to be effective, but they are super expensive. And there literally is not enough money in the United States to have everybody with obesity on one of these medications. That's just the truth of the matter. Any last minute thoughts from either of you?
I'm going to spend my money on a supersized meal from McDonald's.
Huh.
I'm really not.
I think you may need to listen to this episode again.
You're right. No, I think the takeaway message is they're amazing, but they're also amazingly expensive.
I think so too.
Yeah, and the value of a life, versus the cost of a treatment, is just a fascinating thing from an ethical standpoint and from a perspective standpoint. And, to be very, very cold-hearted, which is easy for me, all life should come with a cost. I mean, there should be, as an insurer, as a society, what is the value of a life versus what it costs to sustain that life? And those are hard decisions to make. And in a country like ours, we put a premium on every moment of everybody's life. And again, I think that's why you see some of our costs so high, because we do take that approach. And is that sustainable for the long run for our country? We've all talked about, Medicaid is going bankrupt or Medicare is going bankrupt. And what happens?
Yeah. And these are the kind of conversations, what we're talking about right now is happening there and in private insurance companies. Yeah.
Sounds like an upcoming episode.
Yeah. I'm going to go get my Wegovy while they're paying for it.
I'm just going to wait it out till it goes generic.
Genius. Well, thank you everybody for listening. Thank you, Mark, Mike, Rylan, and Andrew for helping us out. And thank you everybody for listening to this episode of The Health Deli. We'll see you in the next one.
Thanks for stopping by The Health Deli to sample some of our wares. We're open 24/7 on Facebook and Twitter at The Health Deli, or visit thehealthdeli.com to send us a question or find any of our locations. Please come again. We will be regularly stocking the shelves with fresh content and new wellness specials. As always, we want to give a special thank you to Andrew Tingley and the crew at Ferris State University's Television and Digital Media Production Program. Until next time, so long from the Health Deli, where the topics are tasty, the takes are fresh, and the discussion is free.